peripheral gradient designs. The most important aspect when we prescribe multifocal contact lenses to children, apart from the safety, safety and the maintenance and the hygiene part of these lenses, is what is the strength of the relative positive power. Are we going to do a low addition or a high addition? And as we discussed, high additions are more efficacious, but it requires a bumping up of myopic power for this distance. Okay. And again, what is the power profile of the lens? Are we going to use a concentric power or a gradient design? And it's important to also, consider the influence of pupil size, ambient illumination, the influence of these lenses on contrast acuity. And when the toric lenses are still not being explored much, and if the kid has more than one diopter of astigmatism, which apparently most children with myopia have, they would require spectacles on top of the lenses for improved visual performance. Now, coming to binocular vision with these lens designs, it's such a the binocular vision in itself is a complex topic, but when you look at the interaction between multifocal lenses and accommodation and myopia and aberrations and peripheral refraction, there is no one single answer to whether these lenses are beneficial or what is this interaction all about. But what is very clear is that we discussed this accommodation lag theory. So definitely, myopic children, myopes are poor accommodators. I mean, already the accommodation is sort of hanging in there when you're correcting them to the fullest. So when you use multifocal contact lenses or any optical correction or any myopia correction, it could definitely influence accommodation. And the question we need to ask is whether the child is going to be put on low dose atropine or near addition. What is the long-term effect of all of these on accommodation? Because they apparently increase the lag of accommodation in these children. But the current research data shows that what we have is an orthokeratology lenses, that definitely the myopia control is much better on children who have lower amplitudes of accommodation. So as clinicians, we need to ensure that we document some of these basic parameters. And if you have to do at least one thing, it would be near points of accommodation before we jump in and then start prescribing these modalities. And the last two designs, which I'm not going to go into detail, are the positive and negative spherical aberration designs. So because these EDOF designs are designed to manipulate aberrations, there are also other contact lenses which induces positive spherical aberration, because positive spherical aberration is considered to be beneficial for myopia control. And then, so what happened? These are the two research studies. The one that you see on top, where the positive spherical aberration was induced using soft contact lenses, and no evidence with the treatment did not show significant impact on both myopia progression as well as axial length control. And there's another study, the CAMS, which used a negative spherical aberration induced lenses, which also did not show significant impact on myopia control or axial length elongation. So points to consider, sort of wrapping up, always keep visual performance and comfort as the two key matrices whenever we prescribe any optical solution or any myopia control strategy. And when it comes to soft contact lenses, as we know that there are more than one design, there are more than one type, it's important to try out which really is providing that, which maximizes visual performance and comfort. And larger additions are important. I mean, larger additions are efficacious, but that can have an impact on accommodation. So it's important to maintain balance between visual performance and efficacy. But multifocal contact lenses, the effect of the myopia control lasted for a long time, like up to 6 years based on the current evidence. And rebound was also not seen as much as with pharmacological treatments. So once these lenses were stopped, the age expected progression happened, but rebound was not observed. And this still seems to be the best option when it comes to anisometropia, or when it comes to centration and head movements and all of the adaptation factors. So the last thing that's currently going is the combination strategy. Dr. Allen did touch when it comes to OK and atropine are, the results are already there, multiple studies. But this BAM study, where there is this multifocal contact lens and the low dose 0.01% atropine is being explored, but the results are not yet out. It's just a recent study. So we should wait for the results to see how the combination strategy would. And these are my references. And once again, thanks to Team EyeQon for putting this beautiful program together. And I'm done.
Thank you, Dr. Rizwana. Indeed, it was a wonderful session and completely insightful. Thank you for sharing it with us. Let's move forward with our next speaker. Our next speaker for today is Miss Irene Joseph. Miss Irene Joseph is a highly accomplished optometrist with over 20 years of clinical experience. She is currently working as a senior optometrist at Mediclinic City Hospital in Dubai. She is a certified orthokeratologist specializing in this field for over 15 years in Dubai. Welcome, Irene. Over to you.
Yes, hi, good evening, everybody. Let me just share my screen. Is that visible?
Yes, that's visible.
Okay. First, I'd like to thank the team EyeQon for organizing such a wonderful webinar on this topic, especially on the Myopia Awareness Week. And today I'm going to speak on orthokeratology for myopia management. Let me just start off with a little bit of history, where the concept of orthokeratology started back in 1962 when George Jessen mentioned about his orthofocus concept, where he fit the GP lenses flatter than the flat meridian curvature and found that it temporarily corrected myopia when the lenses were removed. So the same concept was also mentioned and named as orthokeratology by Newton Wesley in the same year. Okay, and it was Kearns in 1976 who defined orthokeratology as the reduction, modification, or elimination of refractive error by a programmed application of contact lens, which definition is kind of similar even for these days. And a big revolution happened in the success of ortho-K lenses when the reverse geometry lens was founded in 1990s by Richard Vlodiger and Nick Stoyan. And the FDA approval was obtained for daily wear or the daytime wear OK lens in 1994. And the night wear ortho-K lens was FDA approved in 2002. And this was, of course, much later than things started off in Europe already. So a little bit on the indications and factors to be considered before fitting or during ortho-K selection of patients. In terms of age, it's suitable even for adults and for children, because adults also, this is a mode of myopia correction. So people who do not want to wear optical correction during the day, be it soft lenses or glasses, are also eligible to wear ortho-K lenses once they fit of the effect of its effect on myopia progression control in terms of axial elongation or even in terms of their lifestyle. Because most of my patients love it because they're free to do their sports. They don't have to wear their glasses during sports, especially swimming. And factors to be considered in terms of refractive error or corneal curvature. I don't want to put a number to the limit of refractive error because it's a combination between the two. And depending on the type of lenses used, the amount of refractive error corrected varies. And even if it's a higher refractive error, say in the range of 8-9 diopters, if you're going to design the ortho-K lens, then it can definitely be corrected. And the success of ortho-K also depends, or mostly depends, on the parent-child dynamics. Because as practitioners, we can do the best fitting process and get the best lens for the child. But the success definitely depends on how the parent and the child carry it every day. Because the parent is going to put the lenses on, especially for younger children, say less than 10 years of age, and how they are going to handle it together. So mostly I would always say that orthokeratology is like a family affair. And if practitioners are still thinking about if ortho-K is a suitable option or why take the risk with the lenses in children, then we can see that the International Myopia Institute, which published the white papers and clinical summaries, they mention about the risk of acquiring microbial keratitis, which is like in a lifetime of wearing any contact lens is much lesser than the lifetime risk of vision impairment with myopia, with more than 6 diopters and an axial length of more than 26 millimeters. So to talk a little bit about the lens designs. So the basic design of a reverse geometry lens, it's got multiple curves, and the central curve is the base curve, which is it corrects the refractive error, and the curvature is determined by the flat meridian curvature and the spherical equivalent plus the Jessen factor. And the curve surrounding the base curve is the reverse curve, which is steeper than the base curve. And this creates the myopic defocus, which is very important for the myopia control. And surrounding the reverse curve is the alignment curve, which aids in the centration of the lens. And in higher powers, in higher refractive errors, it helps in enhancing the paracentral steepening. And the curve surrounding the alignment curve is the peripheral curve, which helps in tear exchange and lens removal. So how does this reverse geometry lens work for myopia correction? So the lens is not going to physically press against the cornea. It's going to create a tear film lens between the lens, the actual lens, and the cornea. And this tear film lens is going to apply centrally under the base curve, is going to apply a positive push force on the epithelium. And the reverse curve is going to apply a negative pull force under the reverse zone. Hence, these two forces help in the epithelial matter redistribution, and the epithelium assumes the shape of that tear film lens. And that's how myopia correction happens with these lenses. And how myopia control happens. So Riz has already covered very much in detail about the hyperopic defocus being corrected. And it's the same principle for the ortho-K lenses, where here the soft lens, in the soft lenses, the lens gives the shape so that the myopic defocus is created in the periphery of the retina. Whereas here the ortho-K lens creates that shape on the cornea itself so that the myopic defocus is created. And hence it eliminates the hyperopic defocus, which drives axial elongation. So how do we go about fitting? I'm not going to go into details of the fitting. Just to mention that it can be done in about like 3 ways. One is the trial lens method, where you have a set of lenses and you check the eye, take the eye parameters, and then you choose the lens, apply it on the eye, check it directly, and then decide on the lens that the patient needs. Or you can do it as empirical, where you send the eye parameters to the manufacturer, they do the calculation and send you lenses to try. Or if you do the software-based method, you can have the eye parameters, plug it into the software and design the lens yourself. So whatever the method, you need to get trained and certified in each way, because each brand has its own way of doing it. So to look at the efficacy of ortho-K for myopia control, there are various studies. It's already an evidence-based practice, but just to start, even though there were studies before 2012, this was the first randomized clinical trial. Sorry for the spelling. It's a randomized clinical trial done first in 2012, which was a 2-year follow-up. And it showed that it's significantly, the axial elongation was slower in the ortho-K group than the control group. And in the same year, there came a 5-year follow-up study. It was a Japanese study, where they also found that the group where children wearing orthokeratology lenses had much slower progression or increase in axial length compared to the control group, who were spectacle wearing children. And there are also meta-analysis done. One of it is this study where they analyzed 13 articles, and the axial length change in the ortho-K group was significantly smaller than the control group. So they definitely concluded that it is an effective way of slowing the axial elongation. And there are various other studies also. I'm not going to go into the details of the studies. In recent times, the design of the lens can also be altered. Like I said, the software method where you can really design each curve. They have the myopia control design, mostly for children and for myopia control purpose, where the optic zone is smaller. And there is a myopia correction design, mainly for adults, where the optic zone is larger. So designs can be controlled to get better results from these lenses. And I just want to quickly go through a few cases that I've seen in the past years. The first one is a 11-year-old girl whom I saw like 13 years ago. And she had no ocular or systemic pathology, but there was a strong family history of myopia. The dad was a -9 diopter myope. And I saw her first in June 2010, where she was a -4.75 and a -5 diopter myope. And I've given her the ortho K lenses, and she kept coming for her follow-ups regularly since then. That was her initial topography. And one of her follow-ups, like after 8 years of using the lenses in November 2018, we did a refraction after 6 weeks of washout period and found that she was a -4.5 and a -4.75, which is quite at the same range of refractive error as when she started in 2010. And we gave her new lenses then. And then in 2019, we didn't do a refraction, but we just changed the lenses because unaided vision was still 20/20. And a couple of months of using those lenses, her vision was corrected to 20/20. And if you see the tangential map on the right upper corner of the two maps, the right and the left eyes, you'll see the bullseye pattern. And one of her follow-ups was in 2022, which is 12 years of using the lenses. And after 6 weeks washout period, she was still a -4.75 diopter in both eyes. And new lenses were given. So definitely with the results speaking, her brother also came in August 2019. He was a 10-year-old at that time, and he was a -1.5 diopter myope. So the father was, he didn't even, that was the first refraction, but he didn't want to wait to take glasses. He just wanted to start off with ortho K lenses. So we went ahead and did that. And that was in September 2019. That was his lens on the eye, the fluorescent pattern. And his follow-up was after 10 months also in 2020 September, he was unaided 20/20 vision. So the third case is a 10-year-old girl. She was referred by an ophthalmologist in October 2019. She had no ocular or systemic pathology and no family history of myopia. So when her file number was given, I checked the old records and I found that she started off in 2016 as a -0.75 and -0.5 diopter myope with, of course, some amount of astigmatism. And then she increased to a -2.5 and a -2.25 diopter in June 2017. Within a year, she was like a 2 diopter more. And over the years, her myopia just kept increasing. And in Feb 2019, she was -4.5 and -3.75. But when she came to me in October, she was already a -5 and a -4.5. And her axial length was measured. It was 25.82 and 25.61. So I did the workup and dispensed the lenses. Her vision was corrected 20/20. And since then, she's been on follow-ups. Okay, that's her fluorescent pattern during the assessment. Okay, and that was a topography when she started. And after a couple of months of using the lenses, that was her topography. And after about a year of using the lens, we wanted to see how her refraction was. So we asked her to come after a washout period. And we saw that her refraction was -5.5 and -4.75, like a 0.5 and a 0.25 increase. And axial length was 26.12 and 25.8. That was 2021. And after 2 years, again, we did a refraction. She was -5.75 and -5.25. Axial length again, 26.42 and 26.16. And if you remember, her axial length 2019 was 25.82 and 25.61. So just to see the axial lengths, and her refraction in same February 2019 was 4.5 and 3.75. So about 4 years since she started, her myopia increased by 1.5 diopters and axial length by about 0.6 millimeters, which is still within the physiological limits, I would say. So it really did work for her. And the fourth case is an 11-year-old boy seen in 2016. He started with a -2.5 and -2 diopter myopia. And we had done the workup and given the lenses. And he got corrected to 20/20 in 2 weeks' time. So that was his topography before starting. And about after 14 months, a year and a half, we did a refraction and saw that he was still a -2.5 and -2. And that's when I got to measure his first axial length, and he was already 26.31 and 26.01 millimeters. And that was 2018. 2019, we changed the lenses. And then in May 2020, that's like 2 years after using the lenses, he came for a refraction, and he was -3 and -2.5. And the axial length was 26.5 and 26.19. And if you remember the April 2018 axial lengths, we saw that over 2 years' time, there was a 0.2 millimeter increase in the axial length and about a 0.5 diopter increase in refractive error over 4 years. And the last case is a 11-year-old boy. Just quickly, he came to the clinic in 2016. His error was -2.25 and -2. And in March 2021, like 5 years of using the lenses, we had given him the lenses, of course, in 2016. And after 5 years, his error increased to -2.75 and left eye remained -2. And the axial length was measured. And in after 7 years of using the lenses, he was like a 2.5 and 2. So quite at the same range. And there was a very minimal, like 0.1 or less increase in axial length. So he was 11 at that time in from 2016 to now, like over 7 years. He just increased a very little in axial length also. So to conclude, there's sufficient scientific evidence that ortho-K is a safe option for myopia management, provided it's done in a safe and correct manner. So the long-term success definitely depends on a combination of factors like a proper lens fitting technique, rigorous compliance to lens care regime, good adherence to routine follow-ups, and timely treatment of complications, if any. So these are my references, and I'm done.
Thank you, Ms. Irene, for the excellent session and taking us through the ortho-K lenses, and also for sharing cases. So this made most of the practitioners who's listening here okay to have OK lenses included in their practice. And I would request Irene to stay back, please, for the panel discussion, and also invite Dr. Rizwana to join the panel, please. Unfortunately, Dr. Allen has to go into the emergency to see a child with injury, so he may not be here for the question and answer session. And floor is open for the question now. And also please stay tuned for the myopia quiz. QR code will be shared and the guidelines also will be given by SK. The Dr. is there? Fine, okay. Fine, this is a first question for Ms. Irene. Probably this is for Dr. Rizwana also, because this is combination of OK and soft lenses. So she's asking, is there any evidence of soft OK lenses for anti-myopia strategies? Is this good to dispense in case of high myopia where OK lens and defocus spectacle fail to be prescribed?
So is this going to take that?
I don't know if there is a soft OK lens. So I think it's basically a soft lens, I guess. So if I understand, the question is, what if nothing works? Then can soft contact lens designs
OK lenses for high myopia if other options are not working?
Okay. So first, I will just answer from the current evidence that's available for multifocal soft lenses. The EDOF design, the extended depth of focus design. There is a case series that's been published where none of the existing treatment modality for myopia worked, and those children were enrolled into this particular study where the extended depth of focus lenses were tried out, and it did work. But this study does have its own limitations, both with respect to a very small sample size, and also axial length was not measured in this particular study. So apart from that, there are no other studies where sort of bifocal lenses or soft multifocal lenses were prescribed when everything else failed. I don't have any such studies to quote or clinical evidence as well. I mean, Irene, you can go ahead with yours.
See, basically, it's like myopia control or whatever management is not there's no one-stop solution for it. So you need to have all your options open, and you need to try depending on the resources available and it's a case-to-case basis. Then you decide which option to choose. And definitely nowadays, the combination methods are working out well also. So I think if you have the option and if you don't have other options, it's good to try.
And I think all we need to remember is single vision is not the solution. Both neither single vision lenses,
true.
contacts, or opticals is not the solution for when you already see a progression.
True.
So we have
You
our
need to
next question for Dr. Rizwana, where the audience wants to know how to choose ad when prescribing soft progressive lenses for myopia control.
Okay, I mean, Irene can add to this, as I already put it in the disclaimer at the very beginning. I don't practice these lenses. But again, from both clinical perspective, like I've done a lot of multifocal progressives for myopia control. Opticals I've done a lot. When I want to choose these addition, I basically use binocular vision as an indicator. So I measure the accommodation lag, I measure the near esophoria, and any kid who has a near esophoria and a higher lag of accommodation and lower amplitudes or below average amplitudes expected for their particular age would definitely benefit from a higher addition, and they may not even complain of issues with higher addition. It's always better to go for higher additions, mainly because what we're trying to do in here is to induce this peripheral myopic defocus. So it has to be strong enough to create that defocus, so that then it serves as a stop signal. So this is what I would use, and Irene, you can go ahead.
Yeah, that's right. Actually, the higher the ad, the better. And also these lenses which are made for the purpose of myopia control, soft lenses, if I'm not wrong, they have an addition of +4. And the max available with our soft lenses for progressives, like for as multifocals, they are like 2.5, right? So that's your maximum available with these lenses. So that's the one you should choose if you're going for progressive soft multifocals. But if you're choosing soft lenses specifically made for myopia control, the ad is about +4. So the higher, the better for sure.
Yeah, I have one question for Ms. Irene. That okay, someone wearing orthoke lenses in the night, and he or she came up for the checkup on the next day morning. How do you have any checklist that you can check, like if he or she wear the contact lens the last night and he came for the checkup? Like we need this things like in our practice, as some they are coming the contact lens and reading the 6 vision. So the grading of and all, it's very difficult for us. So do you have any checklist that we can identify these things?
Are you asking like if you don't know that the patient is already using orthoke lenses, and how will you find out, right? So you would not find out by vision alone. Probably the keratometry values, only the corneal curvature is going to give out. So with the keratometry values and with the topography image, for sure you will know if there is.
No, but in the
topography post.
In the topography value also, if you compare, like if you come in the morning, you can check on topography. Maybe come in the evening again, you can do on topography. Then you can compare the value, and then you can might be no. But one time topography also will not give you solution, right?
What was your last sentence?
Like one time topography, if somebody is coming for one visit and you do the topography, and from there, would you like to be sure that she or she wear the orthoke in the last night?
No, once the patient is already using orthoke lenses for a few nights, because there's an initial treatment period, depending on the power, it takes about a week or 10 days for for the complete correction to happen and last for the whole day. That's we call the initial treatment period. So once that is done, if the patient is already using orthoke lenses, then the topography doesn't change during the day. It remains the same, and it remains like, you see the central flattening. So even with one topography, you can identify either he's had a LASIK or he's had a orthoke lens on.
Exactly. So there is no tools, I think.
I couldn't hear you.
Yeah, so there is no tools to identify these things.
The tool is the topographer.
Topographer, yeah. Multiple, like
or if you're smart enough, the keratometer itself you can identify, but topographer for sure.
Yeah. Thank you. Thank you.
Okay. Thank you, speakers, for taking up the questions. And now I would like to hand over the session to Sana. Thank you all once again.
Let's move forward with our today's session. Our next speaker is Dr. Glenda Allen-Malmohipur. She is a highly experienced optometrist, founder and CEO of OK Love Myopia Control Experts, and former president of American Academy of Myopia Control and Orthokeratology, South Florida chapter. Over to you, Dr. Glenda, for the session.
Hello, everyone. Okay, so just give me one moment to upload my presentation. So let me start sharing my screen, and here we go. Okay. So I started with my thank you, thank you slide, and which is a great reminder to thank everyone for being here. So give me one moment while I go back to my initial slide. Here we go. So first of all, I want to thank SAIS and my dear friend and colleague, Celine, for inviting me to join in this wonderful episode. And I'm very honored and privileged to be here on the launch of the episode 1 of EyeQon. Great team, great presentation so far. And I'm so glad that I chose the topic that I'm gonna talk to you about because my colleagues have done an amazing job at talking about myopia, what myopia progression is, and the treatment that we have available. So without further ado, I'm going to start my presentation. These are my credentials. So I graduated from Nova Southeastern University in 2017. And as they mentioned, I was the president for the South Florida chapter of AOMC. These are my financial affiliations. I do consulting for several companies in the industry. And my last, I'm very proud that I got my fellowship for the American Academy of Ortho and Myopia Control. So just a little bit of my life. I have 5 children, and these are all the things that I love to do. So I love coffee, my sunglasses, going to the spa, and first and foremost, my family. So today we're going to talk about axial length and the current research, why it's so important that we are monitoring axial length actively when we are managing myopia. And what is myopia? That is not what I'm going to talk to you about, but we do know that myopia is not just a refractive error. We know that there are no safe levels of myopia, and this is according to the World Health Organization. With that, I'm going to go over to this slide, which is one of my favorites whenever I do a presentation, because this reminds us that if we missed a child from becoming myopic and they come to our office, it's never too late to start myopia management, because we know that each diopter matters. As Mark Willimore and Noel Brennan said it on their paper, why each diopter matters. So we know that for every 1 diopter that myopia increases, this is increasing the risk by 67% of the prevalence of myopic maculopathy. On the other hand, if we can effectively slow progression by 1 diopter, we can significantly reduce the risk of any complication related to myopia. So this is just a visual pictures, because a picture says 1,000 words. So this is why I put this picture here to remind us of why we are all into this and why it's so important that we do myopia management. So to start with myopia management, we first need to establish if there is a risk of a child becoming myopic. So I would say the first thing to do is establish an assessment of the risk factors. So we need to look into family history of myopia, also at the demographics, ethnicity of the child, and ask a lot of lifestyle questions. Once we have determined that there is a status of myopia, we need to determine if there is progression. So by doing that, we can use several methods. One, and the most common one used, is by analyzing the change in refractive error. We know that that's great. However, because it's a subjective measurement, there is high variability on the results that we get, and there is a lot of variability from one patient to another. So there's no referability, and just doing a subjective refraction is not accurate enough, which is why we get to the start of the show today, which is what I'm going to talk to you about, and is axial length. So we know that axial length, we have great instrumentation that allows us to have reliable, accurate results, and it is the gold standard for monitoring myopia progression. So ocular biometry has really changed the game in myopia management, because since now we have so many different instruments, ocular biometry is something that was reserved specifically for ophthalmologists. Now we are using it in the optometry space due to the accessibility and the new technology that is available. So ocular biometry, we know that it is an instrument that we're going to be using to measure the anatomical dimensions of the eye, and those measurements are going to be done from the anterior surface of the cornea to the anterior limiting membrane in the retina. There are two types of ocular biometry. So we have the contact biometry and non-contact tonometry. So in ultrasound, we have two different ones. So we have contact, which is the one where we are going to directly place the probe onto the cornea. And then we have immersion biometry, which we're going to use essentially a scleral lens filled with saline solution to take the measurement. With ultrasound, one of the advantages is because we're using a scleral lens, and we're filling it up with the saline solution, there's no direct contact to the cornea, so that is going to be beneficial when we compare it to the contact biometry, because we are minimizing the compression factor to the cornea, which can and sometimes gives us results that are not as accurate. And it could also give us a overestimated load reading. So when we are choosing to purchase a biometry for our offices, because we want to start monitoring axial length, it's important that we keep these different points into consideration. So we want to get the equipment that is easy to use, because we're working with very little children, and we also want to minimize the errors that are going to be induced by the use of the instrument. So when looking at ultrasound, if you have to choose between one or the other, I would say that the immersion is going to be safer and it's going to give you more accurate results, because we are eliminating the compression factor to the cornea, so we get more accurate results. And also because we're not placing the probe directly onto the cornea, we are going to minimize the chances of a possible cross-contamination between patients. So between ultrasound, when we're looking at contact and non-contact, I would say that the contact, it's going to have, it's great. This is the one that I actually have in my office, but I do have an optical biometer now, because this one here was the first one that I got, because it's more accessible. It's not as expensive as the other optical biometers. So, however, this one I have found in my practice that because we're putting the probe directly into the cornea, it's not very easy to use with young children. They are very apprehensive about having something come close to them. So these are the type of things you want to keep in mind if you are looking into purchasing a biometer and you're trying to decide which way to go. So this is a little more detail into the ultrasound. And as I mentioned before, here you can see in the picture that we're using a scleral shell to take the measurement. And we are also seeing that I kind of went a little bit ahead of my slide, so I already told you everything here. Basically, it's just doing a summary between the two, contact and non-contact. And when we did studies on looking at the different biometers, we have seen that even though there is some error on the compression factor, it's not clinically significant. So optical biometry, we have two different technologies that we use. So one is using the laser partial coherence interferometer, and the other type of optical biometer is going to be using the optical low coherence reflectometry, or OLCR. The first PCI biometer that was introduced was actually by size, and it has been the standard of care for biometers for a long time, which it is the IOL master. The one that uses the LensStar is going to use the OLCRI technology, and this one has an advantage because it also has the reports where we can monitor myopia. If you are using it specifically for myopia management, it actually gives you a report, and it shows you where the child is in relevant to the growth curves that we have. So this would be one advantage if you are looking into myopia management, because it gives you that report that is very useful when talking to patients and parents about the effectiveness of the treatments. So this is a summary basically on the two different types of biometers. One of the advantage of optical biometer is that we have low risk of patient cross-contamination because there is no contact. There is no need to use anesthesia because we're not really touching the cornea. And optical biometry can also perform keratometry. So if you are an ophthalmologist, you don't need to have an instrument to measure the IOL power. With the OCLR and the PCI devices, we also have comparable performances. So there was a study that compared both optical to ultrasound biometry and didn't find any significant difference. There's a lot of research as to how axial length relates to myopia management. So this is just a couple of the articles that I found, but there are several more. I posted them here in case anyone wants to read a little bit further into it. Definitely not enough time to go in detail on all the studies, but all the studies basically do agree in the fact that axial length, it's the best way to monitor for the effectiveness of treatments, and also it is the most reliable, most accurate way to monitor for myopia progression. So axial length, now we're going to dive into as it relates to the treatments of myopia management. So we all know, as my friends, colleagues have explained before me, that all the treatment options that we are using in myopia management, the aim is to reduce the elongation of the eyeball. So whether we're using a pharmaceutical solution like low-dose atropine, or we're using an optical correction like the soft lenses, Ortho-K, or even optical glasses for myopia management, the aim of every single treatment, regardless of the way they work, is to slow down the elongation of the eyeball. So it just makes sense to me that if that's how the treatments work, that we would monitor the axial elongation. So the benefits of measuring axial length compared to just looking at the refractive error is that we know that it is repeatable, it's reliable, and it's accurate. With refraction, as we know, if we are going to be using refraction only because you don't have a biometer right now, then I strongly urge you to only check for refraction under cycloplegic conditions, because that's going to give us a little bit more repairability when we're doing refraction error as a mean to monitor for progression. In order to understand, now we got a biometer because we're very good clinicians and we want to do the best thing for the patient. But if we have these great instruments and we don't know how to understand the data, that doesn't really help us a lot. So these are the normal axial length means. These are based on the study that Tiedemann did in 2018 as one of the most popular papers that is being used in the space for myopia management right now. And these were their results at the studies. They did a meta study where they analyzed over 1,200 European children. And so this is important to understand that these results are based on the European children population. So there's going to be slight differences depending on the cohort that was used for the studies. So when you analyze all these studies, it's important to keep in mind that axial length is strongly related to age and gender and also ethnicity. So we can see here that at 6 years old, the mean of the axial length, this is for emmetropic children, was 22.36. So this is very important. And I would say if you have nothing else from this presentation today, I would take a picture of this slide and know these numbers, because I have found these to be very useful in clinical setting when I'm educating parents, because I can use these and just say, this is the axial length of your child. She's 6 or 9 years old, and this is what the norm should be. Of course, I let them know this study was done in Europe, so these are European children. But this gives us a baseline so that if we have nothing else, we can take the axial length from our patients and compare it to where they should be, more or less based on their age. So great information here. Also, I think it's important to see here that the axial length of the eye ranges from 16.8 when we are infants to around 23.67 at adult, with a little bit of a standard deviation. Another great piece of information that I think we need in order to be efficient at interpreting the axial lengths that we are getting from our patients is to understand the typical change for an emmetropic child. So this is what, if you have a normal child who doesn't have any myopia, and I'm sorry, I shouldn't say normal, all our kids are beautiful and normal, I mean emmetropic. And a child, it's going to be between 4 and 6 years old. You can see that they are going to be changing a little bit faster. So this is not meant to give you these numbers and for you to memorize them, but to understand the bigger picture. And I think the bigger picture here is that we can see that children are going to progress a lot faster when they're younger versus when they get older. So this is important to understand if a treatment is being effective when we're monitoring this axial length when the child is coming back. I have to confess, when I started monitoring axial length, any elongation that I would see, I would assume that it was due to myopia and that this child was progressing. So I did not understand this. I didn't have this. So I think that this is really important, because understanding the normal physiological change that is related to the somatic growth of a child, it's important. So when we are taking a reading of an axial length, let's say we have a patient that is 7 years old, and we're looking at their axial elongation, and we have a change that is between 0.1 to 0.3, that's actually not, I would say that's not really myopia progression. I would say the child is within the standard deviation of the normal eye growth for their age. So if I was treating that child, now I can use this information and show the parent and tell the parent the treatment is working as expected. Years ago, when I didn't have this information, I would just assume that all of that elongation was due to myopia progression. So this is very important to know. The main point to remember is that younger children are going to have a longer eyeball, it's going to be growing faster, and that it's going to slow down once the kid reaches their ages between 12 to 15 years old. We also know that after 15 years old, most kids stabilize and their axial elongation doesn't continue to grow. We also know that any progression in an adult would be considered myopic progression, because an adult their eyeball should not be growing anymore. So the difference in, this is to illustrate to you the difference in ethnicities. So when we are looking at Irish children, they were very similar to German children. And when we look at Chinese children in Shanghai, they were also, the axial elongation was similar to Chinese children in Wuhan. So what we see here is that the ethnicity, it's a more critical factor when it comes to the way the axial length develops versus the demographics. We also saw the European and Chinese, when we compared European and Chinese children, all the European children had shorter eyeballs compared to Chinese kids. And we know that this correlates or reinforces the fact that we know that there is a higher prevalence of myopia in the Chinese population. So thanks to Tiedemann, now we have normative data. And what this study did, again, we're still referring to the same study, is that they analyzed over 1,200 children in order to establish normative information so that we can look at these charts now, and we know that all children who are below the 50th percentile have less risk of developing high myopia in adulthood. And conversely, we know that all children that are in the 50th percentile or higher will definitely develop myopia and will have a higher risk of developing high myopia when they are in adulthood. We can also see that young girls progress a lot faster than young males. So the chart here on the left is for boys, and the chart on the left is showing the results on girls from 6 to 9 years old. We also know now that if we can determine the axial length of a child at 6 years old, it is a very accurate predictor of where their myopia is going to be when they are 9 years old. So this now gives us a great tool that we can use to educate parents, we can educate the children, but most importantly, as clinicians, we can make a better educated decision, and we can see if a treatment is really working well and is being effective. So having these 3 young children that came to my office, and in America, we have to ask for permission when we're gonna post a picture. So we do that in our offices. These are 3 siblings. 2 of them came for an appointment. And as much as, you know, I love measuring axial length and I know how important it is, I didn't want to lose the opportunity to get the baseline reading for the young child that wasn't on my schedule. So I went ahead and got the axial length for the young child as well. And what you can see here is the 3-year-old, who is the youngest of the 3 sisters, who was not scheduled. Her axial length is rapidly approaching the same axial length of the 6-year-old. So I can already tell just by doing this, I could speak to the mom and say, as you can see, she's quickly approaching, her axial length is growing, so we know that she's going to develop myopia very soon. This is how we can use axial length in the clinical setting very, very effectively. But I think it's important that you understand what is the normal growth expected, what is the axial length for the age of the child, so that way we can do the comparison. And also, once we have that information, you can go a step farther and plug it into this chart. So these are the 3 same girls, and we can plug their numbers and put it into the chart. It's not going to be as accurate, of course, as if we had an instrument that was doing it for us, but you can extrapolate the data and plug it in, and this way you can educate the parents and show them the risk factors. So here we can see that the 4-year-old will definitely have high myopia as an adult. And we can see that the 3-year-old, at least for now, it shows that she also will, is above the 50th percentile. So she most likely will also develop myopia. And we see that out of the 3 girls, the 6-year-old is the one that has the lowest risk. So now we're going to review some cases. And this is a 9-year-old Spanish female. You can see here her axial length is 24.19 and 24.25 already. And this is her entrance manifest. Because of the amount of astigmatism, we decided to start her with atropine. And you can see here, her axial length had not changed much. Since 2021, we started at 24.19. And when she came in after 1 year, in October of 2022, her axial length had not progressed much. We also see the same thing for the left eye. So her change, even though it has changed, is within the range. So the expected change in the axial length for a 8 to 12 years old is 0.2. So even though she did progress a little bit on the left eye, it's still within the normal range. This is another case. This one is, we decided to fit this patient because of the difference in her prescription with a soft multifocal lens. And you can see here that it was also very effective. And we had over a year, we had a progression of 0.06, which is excellent for her age. We expect to have an axial length change of 0.2. In her case, it changed by 0.6. So that is great. And finally, we also have a case of ortho K. This was a patient that is 11 years old, had a great parameters for ortho K, was a great candidate. And the point of this was to show that in all three different treatment modalities were very effective at reducing axial elongation. So when we're looking at studies as clinicians, we always want to validate our sources and practice evidence-based myopia management. It's also important that when we're looking at these studies on axial length, we consider why care for myopia. This is a paper that I highly recommended if you like to look at studies, because it's showing you how to analyze the axial length. So basically what it's saying is that we can't just look at one random reading of an axial length, but it's important that we follow axial elongation over the course of the entire treatment. And we need to look at the cumulative reduction on axial elongation over time, rather than just be looking at one reading compared to the baseline. So this is where I like this paper. I think it gives a better understanding on how to interpret this data when we're reading studies, because they can be quite confusing. I like to always compare when I'm lecturing here to my colleagues in America, which were very aggressive, and I'm sure it's the same everywhere else. When we look at a patient who is a suspect for glaucoma, we are very aggressive. We always educate the patient and we do OCT. So a lot of optometrists here are also able to manage glaucoma. And we are doing a very good job at managing glaucoma. So I like to make the comparison between glaucoma and myopia, because I think that there are factors that correlate. So refraction to me in myopia is equivalent to having a visual field exam. So a visual field is great, but it doesn't really give us the whole story on glaucoma. So in glaucoma, if we have a patient that is a suspect for glaucoma, we do an OCT because we know that it's an objective way to evaluate the structures of the eye. So glaucoma to me and myopia relate in the fact that we should be doing axial length for our myopia patients, just like we do OCT for our glaucoma patients. When we are looking at the repairability and the accuracy, we know that it's extremely accurate when we measure axial length. It's to the 0.05 millimeters. So with that, I just like you to think of when we're seeing a patient who is myopia, take the same care of them as we do with our glaucoma patients. We need to do education and we need to do the proper testing to make sure that we're monitoring and we're treating these patients the best way that we can. So axial length to myopia is to me what an OCT is to glaucoma. And the refractive error is analog to doing a visual field. So what would we do if you have these cases? So these cases to show you that axial length and refractive error doesn't always correlate. Here we have two different patients, and we can see that the patient A has a very low refractive error, but his axial length is very, very similar to patient B. So when we're looking at these patients, axial length can really make a difference on how we interpret these cases and the way that we're going to decide to go with the treatment. So in this case, even though the patient B has a higher error of myopia, it is actually more, you have to think, okay, is this more refractive myopia versus axial myopia? So they have steeper corneas, which is also going to contribute to some of that myopic power. So that was the point of this slide. The key points to take away is that axial length is a key for determining myopia management. Is also a very repeatable, accurate measurement. And we need to be familiar with the normative data. We need to understand normal growth or somatic growth versus growth that is due to myopia progression. And if you don't have anything and you don't know where to start with myopia, I think that measuring axial length is definitely the way to start. It's a great practice builder because very easy to start the conversation. And my takeaway point would be always take a baseline axial length, schedule the patient to come back so we can monitor, because when the patients can see the baseline axial length and then they get to see in 3 months, if you do another measurement, that their eyeball is growing, that usually is going to give them a clear picture of why we are trying to do myopia management for the children. So one thing that I like to leave you all with is when we have a moment of decision, the best thing that we can do is the right thing. The next best thing we can do is the wrong thing. But the worst thing we can do is do nothing. So thank you so much.
Thank you, Dr. Glinda, for the lovely session and taking us through the biometers and the sharing vital infos and the importance of documenting axial length as a part of a myopia control or even otherwise also. Okay, now moving on to the next talk, I would like to invite Mr. Murtaza Ibrahim Madraswala. He is a professional optometrist and a research scholar with closer to 2 decades of experience in various fields of optometry. Currently handling Rivoli Vision Academy, anchoring all the optical and dispensing related trainings. He's going to take us through spectacle options for the myopia control. Over to you, Mr. Murtaza.
Thank you. I'll just share my screen.
Yes, please.
Okay. Hope my screen is visible.
Yeah.
Thank you for that lovely introduction, and thanks for the opportunity to be a part of such a lovely program. To start with, apologies. I'm sort of not keeping well, so maybe there will be some voice, this thing which may not go well for the presentation, but nonetheless, I can repeat stuff wherever required. So today I've been given this opportunity and I would say a responsibility to share about myopia control spectacle lenses. And yeah, we have been through a lot of research, a lot of evidence-based practice on the atropine, on the contact lenses. So now, let us quickly dwell into spectacle lenses. What I'll be doing is like quickly passing on like few slides which when the concepts were really well established by my colleague Rizwana and also earlier by Dr. Kalin. And thanks, Dr. Glenda, for putting light on the axial length, because I'm just going to speak more on in terms of efficacy of these spectacle lenses from 2 perspectives majorly, one on the prescription, the other on the, sorry, not prescription, refraction, and the other on the axial length. So just moving on. As we know, like, again, no financial interest. The images and the pictures used in the presentation is only for the educational purpose. And I would like to start with, like, and this is the information which all of us have. And by 2050, half of the world population is expected to be myopic. And that's the reason we have this Myopia Awareness Week. And all of us on this platform discussing about possible actions that we can do from our end. Prevalence of myopia, this is just one study which was done in India, basically to understand what is the prevalence rate. And again, it is in line with many studies that were done across the world, like 50% of the population is expected to get into the myopic zone. On this particular area, like myopia progression, the progression I would want to highlight basically on the years, basically 6 to 10 years, wherein the progression is found to be highest, and it keeps moving till 26 to 30 years. Axial elongation, the concept of hyperopic defocus, myopic defocus was well explained earlier. Basically, if I have to just summarize this slide, light falling onto the retina, and in the same light, if it is dragged to the periphery, you will see that a hyperopic defocus is formed, and then the whole idea of having a myopia control is to aim at the myopic defocus. So just for us to have a quick and easy correlation or relate the stuff, wherever I'm talking about hyperopic defocus, it's the light rays actually passing beyond retina, and myopic defocus wherein we want to have the light rays falling in front of the retina, which is the peripheral retina. So peripheral defocus, we have been already speaking, so I'll not be going through this slide. Here, as my colleague already highlighted that be it a single vision spectacle lens or the contact lens, when it comes to the central plane, it really corrects the myopia, but when it goes to the peripheral retina, it sort of creates the peripheral hyperopic defocus. And the aim now here is like, make sure that the light rays which actually comes in from the periphery falls in front of the peripheral retina. So a sort of, myopic defocus which can be created, but making sure that the central zone is well corrected. Now, this is what I've explained in the previous slide. Uncorrected myop is like, this will be the image shell. For the traditional correction, the rays falls on the retina, but then there is a hyperopic defocus. So optimal correction should be a lens which can actually form everything within the retina. Now, the main agenda for my presentation is to focus on the treatment option, which is spectacle option for myopia, and I'll be just briefing on that. So basically, to keep it very simple, the spectacle lenses for myopia are in 2 generations. Maybe I'll just split it into the first generation, which is progressive addition lens and bifocal, and the second generation lens, which is specifically designed, I would call it like, just for a simple understanding, a single vision lens. But all these lenses, like we will be discussing these lenses, which is DIMS, HALT, CARE, and DOT. CARE part of it, I'll just leave it to my colleague Celine to take care of. But commonly for the second generation lens, there are 2 important aspects that we should be aware of. One is your clear zone, which is centrally in the lens, and then you have a peripheral zone, which is a treatment zone. So we will speak more about the concepts of the treatment zone in the coming slide. But let me first dwell into the first generation of myopia control lenses. Just for our understanding, progressive addition lenses, we know very well that one single lens will have a correction for distance, intermediate, and near. Now, what happens basically from distance till the near, there is an add power which keeps increasing, and because in myopia control, we speak more about the concept of myopic defocus. The addition in the lens helps creating that defocus for the retina. Now, the only thing is here, when we go through other slides, you will get to know that progressive lens, in terms of efficacy, is not to the mark. So there's a study which was published, a common study, and according to the study, the progressive lenses, when compared to single vision, actually showed the progression of myopia, but it was very small, though statistically significant, but clinical implications were really nominal. So the other option which was there in the first generation was bifocals. Now again, for bifocals, for the progressive myopia, basically bifocal lenses with addition and again prismatic bifocals were also considered. And based on the overall progressive and bifocal combination, There were lenses available in the market, and I have two studies which actually speaks about the efficacy. Now, near vision addition progressive lens, which is at the bottom, basically the overall efficacy was 14%, and the efficacy was higher for children with esophoria and accommodative lag. So near about 37.2%. Now, when we say efficacy of 14% or say efficacy of 37.2%, basically for myopia control based on evidences, any treatment which can actually have efficacy of about 50% is considered to be a standard which can be considered for application of myopia control. Now there was executive bifocal which was considered, and these bifocal also had pre-prism base in, and these bifocals were actually showing a better efficacy, which was 51% in children age 18 to 30, 8 to 13. I'm sorry. So limitation basically with first generation was there was no 360-degree effect. My colleague Rizwana already spoke about contact lenses. Beauty with the contact lenses was all over optics 360-degree, and the whole effect of having the myopia defocus was all around. But with the first generation lenses, basically, be it a bifocal or progressive lens, it was only at the bottom half of the lens. PAL efficacy was better in children with esophoria and high accommodative lag, but then when compared to progressive, executive bifocal were reported to have a better efficacy. But then again, with the executive bifocal, there were some cosmetic challenges which were reported by parents and getting adopted to that particular modality. So now there was definitely first generation which was introduced long back, but then there was always an improvement which was needed, and then the next generation of myopia control lenses stepped in. So when we talk about the second generation of myopia control lenses, here we have like 4 major design wherein there is a lot of evidence available. I'll be talking about DIMS, which is defocus, incorporate, and multiple segment. I'll be talking about HALT, which is highly aspheric lens-led target. CARE, basically, it stands for cylindrical annular refractive elements. And I think this will be covered in the very next session, which is handled by Salim. And then we have again like a concept on contrast, which is diffusion optics technology. Moreover, all the lenses works on a similar concept of peripheral defocus, but diffusion optics technology works on the concept of contrast. So we will be just dealing with it quite quickly, so to understand in what way it is different from other myopia control options in the spectacle lenses. So going ahead with DIMS, basically, as I said, like, all these second generation lenses have 2 zones. One happens to be a central clear zone and the other happens to be the treatment zone. Now, to understand DIMS further, the central zone is 9 mm. Okay, and all these treatment zone has a power of plus 3.5. Okay, so the treatment zone will ensure that it will create a myopic defocus and thereby help with the treatment or controlling the myopia. Now, in total, there are about 400 multiple defocus segment, and overall, this is spread across a diameter of 33 mm. Okay, so the center 9 mm happens to be the clear zone, which will have the prescription, and the 33 mm treatment zone will have about 400 multiple defocus segment, which will have plus 3.5 diameter on each side, and every diameter of every lenslet is 1.03 mm. Okay, now this is the basic anatomy of this lens. Now let us see the efficacy. Basically, DIMS lenses have the highest trial done, like say for up to 6-year study is available, but efficacy is here what I have highlighted is for 2 years. So Around 50% refractive and 60% axial length efficacy was found in Hong Kong Chinese children, okay, with an absolute effect of 0.44 diopter, okay, lower refraction. Now, the paper also reported that 21.5% of children who wore DIMS had no myopia progression over 2 years, compared to only 7% those who wore single vision lenses. So the efficacy with this lens is really good. If I have to just quickly some brief on how these lenses are fitted, then the central zone is 9 mm. It is fitted on the pupil. So pupillary distance and the fitting height has to be accurate while fitting these lenses or any lenses for myopia control. Going forward, now this is one important slide which most of us as a practitioner would be interested in. Vision from the treatment zone, basically. So here, from clear zone, wherein we have a complete refractive error corrected, the vision is going to be good. But then what about the treatment zone? So there was a review done by in the review of myopia management, and it has come up with very interesting finding. Off-axis distance visual acuity, the reduction in reading the letter was 3 to 6 letter in a particular study, and then a study done in 2020 actually showed 2 to 3 letter reduction in children, and 3 to 8 letter reduction in adults. Now, basically, like children and adults, why we need this value is because for children, the initial awareness is just made peripheral blur when there is a subjective performance. But for adults, there may be eye strain, headache, nausea, and necessity to adjust to the spectacle. So we need to keep this in mind when it comes to DIMS or when you're planning for myopia control in juvenile onset. Now going ahead, the next design which I would want to discuss is HALT design. Now this is highly aspherical lenslet target, which is the concept, and basically it works on creating a volume of myopic defocus in front of the retina. So as you see here, the lens will have a volume of myopic defocus which is created, and basically if you look at the lens will have a center zone which is 9 mm, which is similar to what we discussed on DIMS. And then there are 11 rings which are having 1021 contiguous touching aspherical lenslet. Now, here the power was not straightforward as it was mentioned for DIMS. Basically, I had to do a lot of research to understand what kind of power was actually incorporated on this. As you can see in the previous slide, there is a different volume of myopic defocus being created. So one study actually pointed out that the first 5 ring basically had a power of +6, and then with every ring it started dipping till the last ring which had a power of +3.5. So here the rings are having different power. Basically, when we talk about the design concept, it from the manufacturer or from the designer, it's like they speak about creating volume of myopic defocus, but not in particular the amount of addition which is used on the lens to create that defocus. Now, efficacy on the HALT design, basically around 70% when it comes to refractive and 60% axial length efficacy. Now, this basically one important thing which I want to highlight here is children who wore HALT design lenses for at least 12 hours per day, 7 days per week, were found to have axial length and myopia, which was respectively lesser. So the overall effect of the treatment was higher when they use the lenses continuously. Now, again, the very same study also spoke on the vision zone from the treatment, vision from the treatment zone. And when we say on-axis distance visual acuity, no major significant difference. When we talk about off-axis, not from the center zone, but from the treatment zone, then it was 3 to 4 letter. And when we talk about impact on the contrast sensitivity, then the contrast sensitivity was slightly lesser. Now, impact on the subjective performance, basically no significant impact reported after 3 days of wear. So this clearly brings out that these lenses are faster in terms of adaptation. Now I'm just moving on to like in between. I have not spoken about care, but that will be covered in the upcoming presentation. I would want to just highlight on this novel concept. I call it as novel concept because it works on a different principle altogether. The hypothesis here is that high contrast signal at the retina photoreceptor is induced. Receptors induce the eye to grow. So high contrast will induce the eye to grow, and low contrast signal will signal the eye to slow the growth. So high contrast and low contrast, sequence is taken, and the lenses are designed in a way wherein the contrast is lesser in the treatment zone. Now, how it works? The lens looks like this. Basically, you can see the central zone comparatively to the other designs. The central zone is smaller, and the peripheral zone doesn't work on the concept of having a plus power, but these are like micro dots that will softly scatter the light, thereby causing a reduce in the contrast. A reduction in the contrast on the retina will send a signal that the eye should not be going further. So this is what is highlighted here. It's like central zone, which is 5 mm in diameter, and the treatment zone is micro dots. Doesn't appear to affect vision, and when looking to the treatment zone, the image becomes softer. But then the participants who have been using the lenses, the tolerability is really well. So diffusion optics, like again here we have evidence of slowing the myopia progression by 59%, and this is over a period of 2 years. And when we say technology, the microscopic diffuser is around 1/10 of a millimeter, very small diffuser. And basically, only we have the first year data in the younger children, 6 to 8 years, and it has been reported that 59% efficacy is there. Now, compared to DIMS and HALT, basically the clinical data is for children between 8 to 13 years. So this is in dots. We have the data for 6 to 8 years. Now, to summarize, basically, all these new generation of spectacle lens design the efficacy is really well, like about 50% when compared to the first generation. The data that we have from the clinical trial study, like evidence-based practice, if you have to call it, then DIMS and HALT have data for 8 to 13 years. Both the studies are now reporting 3 years data, and it is presumed that it is effective in kids from 8 to 16 years. Studies from DIMS. Okay, and the dot lens has been studied in children from 6 to 10 years, and the data what was reported is only for 1 year so far. Now, if the children is younger or older than this, then the treatment may still work for them, but the expectation for the treatment may need to be adjusted. So I'll just wait for the panel session to answer the questions, and thank you. Over to you, ma'am.
Thank you, Murtaza, for taking us through optical lens options for myopia control. It was indeed helpful for us to understand and learn in detail. Please wait for the panel session while we set the panel for discussion. I would also like to call Dr. Glenda for the panel session. While the stage is being set for panel session, I would just like to give a piece of information for the audience. Our Myo quiz QR code will be put up soon. So stay tuned for the quiz session after the next session.
Can you please start, Sana?
So I think we need to start the panel session. I think Mr. Murtaza is missing. Yeah, he's also here. So let's start. So we have a question for Mr. Murtaza. Is there any frame selection criteria that needs to be kept in mind for kids while considering these lenses for myopia control?
So basically, like when it comes to frame selection criteria, we need to actually follow the same criteria which we follow for selecting kids for the pediatric vision. There's no additional criteria when it comes to frame. But yes, the precaution has to be taken, or caution has to be taken when it comes to fitting these lenses on the frame. So as I said, like we'll need to have a proper pupillary distance marking and the fitting height. Second important thing is also like when we consider pediatric frames, the frame sits closer to the face, the pandoscopic angles are lesser. But then if it is higher, then the compensation has to be done. Again, it is from the measurement aspect. All I would say is like, selecting frame, make sure that the width is good enough, make sure that the frame is not too heavy, make sure that the splay on the nose sits well so that kids are really comfortable with using those.
So we understand that the frame selection criteria remains the same. There's no special consideration for selecting a myopic control lens.
Exactly. Yeah.
Okay. All right.
Okay. I have a question for Dr. Glinda. There's a question like, what is the proposed time period to check axial length in children during the treatment, during the myopia treatment?
Definitely. So once you establish your baseline, I like to bring my patients back in 3 months.
Okay.
And then after the initial baseline 3 months and 6 months, I have them on a 6-month schedule.
Okay. Thank you.
Thank you, both the speakers, for enlightening us with the knowledge today. Let's move forward. Over to you, Kani.
Thank you, Sana. Okay, now I would like to invite Ms. Celine Combros for the sponsored talk. Ms. Celine is currently the Zeiss Medical Liaison Manager for Middle East and Africa. She's in charge of myocare lenses, has worked for EyeQon, handling contact lenses and dry eyes. Over to you, Ms. Celine.
Hello, everyone. I'm really, really happy to be with you tonight. Could you please tell me if you can see my screen?
Yeah, it's visible.
Okay. Okay. So first of all, I'm really, really happy to be there tonight and to have all those together. It's those very, very interesting conversation about myopia management, especially here in the region where unfortunately not all of those techniques are available. And so having the possibility to come and talk about myocare, this new age-related lens is really, really great. So I really want to thank you, all of you, for giving such a concern for myopia pandemic and to try to find solutions and best practice. So really thank you, everyone. So yes, I'm here to talk to you about myocare. Many things has been said since the beginning of this webinar. So I believe you already know a lot of things that I'm going to say, but I still do believe that some context is really important to understand how deep and how important this pandemic here. Right now in China, 90% of the children below 20 years old are having myopia. Okay, it is the heart of the pandemic, and it's not that fast in the rest of the world, but it is still very fast. It is also said by 2050 that 50% of the population, the worldwide population, is going to have myopia. So you have to, as optometrist, as ophthalmologist, to prevent and to find best solutions for your patients, because it's really something which is having very, very big damages. And LASIK is not the answer. I know that most of the time when I'm visiting doctors here, ophthalmologists, they are saying that parents are really not into myopia management, because to them, LASIK is going to be the answer once myopia is going to be stabilized. But what they do not understand is that all the retinal damages are irreversible, and so that LASIK is not going to cure that. So, as said previously by some of you, yes, only one diopter increase many risks for myopic maculopathy, open angle glaucoma, posterior subcapsular cataract, and much more. Which means that even one dioptry, if you can slow down myopia even with only one dioptry, we definitely can improve the health of the children. So yes, here it is. This is MyoCare lens. I'm really happy to talk to you about this lens. This is the agenda of this presentation. First, we're going to talk about this peripheral defocus theory, but I do believe that now all of you are really into it, because it was a big part of all presentations tonight. Then I'll explain how MyoCare is creating this myopic defocus and what technologies are into the lens. Then we'll talk about studies results and some additional information, availabilities, and a toolbox for you to work every day. So yes, as it has been said, oops, sorry, I'm too fast. This is a children wearing a single vision classic lens. Okay, so all the rays going through the optical center are directly going to the fovea. Okay, unfortunately, all the rays coming from the peripheral part of the lens are not going to the fovea, to the retina, but behind it. Okay. This is what we call a peripheral hyperopic defocus. Then this part of the retina is actually very sensitive. And so a signal is going to be sent to the brain, which is the elongation of the eye, to bring back this image on the retina. This is why myopia reappears in a constant feedback loop. You have myopia, you wear glasses, you have this hyperopic defocus on a single vision peripheral part lens, okay? You have this biological reaction, which is the elongation of the eye, and then you have again myopia, and again, and again, and again, and again. So it's a constant feedback loop. So how do we stop that? What are we going to do to send a stop signal to the brain? We just said that it is a hyperopic defocus, which is actually an undesirable side effect of a corrective lens, which is stimulating myopia. To stop that, we are going to do the opposite. We are going to create myopic defocus in the peripheral part of the retina, which means that the image is no longer going to be behind the retina, but in front of the retina. So the stimulation, which is sent to the brain, is no longer there. And so there is no more elongation. This is our goal. This is what we want to do. But how are we going to create this myopic defocus? We are going to add a positive refraction at the front surface of the lens on the periphery. So how do we do this? Yes, we do have two different technologies in the lens. The first one on the front surface is what we call CARE technology. The second one is on the back surface, and it's a clear focus geometry. First of all, what I want to say is that, as Murtuza said, right now in the market, okay, they are not available here, but right now in the market, you have many, many different types of lenses. Some of them are doing dots, some of them are doing rings, some of them are doing different shapes. We decided to have those rings because this is a shape which is strongly working through the brain. This is a print from AutoK on the cornea once you remove the lens. This is also a design which is used for soft contact lenses. And so, yes, this is why originally we decided to go into rings to create this myopic defocus. So Zeiss has been in the myopia management industry for more than 20 years now. At first, I mean, we are still, but our main market was Asia, right? We tried many things. We had progressive lens, we had different type of lenses. What is very challenging on an optical lens, not only optical lens actually, in myopia management, is the wearability. If the wearability of the myopia management technique is not good, it's never going to be efficient. And this is what is happening with a progressive lens. When you have a lens with a plus 2.5 addition, right? For a 6-year-old children, even an adult cannot adapt. So can you imagine the children running all around playing? This is really, really hard. So when we were studying about myopia, what we really wanted to do is to find the best balance between efficiency and wearability. So what are those parameters into this balance? The first one is, as you can see, what we call the central zone, okay? This central zone is where you have the regular correction. So we had to find the perfect size to maintain a very good comfort. Then you have the functional zone on the peripheral part. Here you have those scare elements, cylindrical, annular, refractive elements, which are going to create this myopic defocus, which is a blur, right? And between each element, you will have the normal refraction. The idea here is to not compromise good vision and the myopic defocus. So we also had to find the best distribution between myopic defocus and normal vision. So how is a design of a myopia lens? This is a cut, okay? So you have this central zone. We have been trying 12 prototypes of myopia in China before picking the ones we wanted to try, to keep. So this clear zone is having the best comfort and efficiency for a size of 7 millimeter to 9 millimeter. Then you have the microstructure, okay, so the care elements, which is going to create this myopic defocus. And between each care elements, you have the normal correction. The field factor, the distribution of the surface is 50-50. 50% of myopic defocus, 50% of good vision, and a clear zone of 7 millimeter to 9 millimeter with a normal vision, okay? So all those parameters together are going to make this lens comfortable, so wearable, and with a very good efficiency. So what is happening here is a children having myopia wearing a myocare lens. So as a single vision lens, all the rays coming through the optical center, okay, whereas a regular correction are directly going to the fovea. Then you have rays coming from the peripheral part. Some of them are going through the care elements, and so the image will not be on the retina, but before the retina as a myopic defocus. Then you have rays coming through the regular correction, so the image is going to be on the retina, and so on, and so on, and so on. This is what we are calling a competing myopic defocus. But what we want is to find the best way, of course, to get the best wearability and efficiency, but we want this to be quick. We want this stop signal to be really sent as fast as possible. And so what we understood is that if we do a myopic defocus with a single dot, the message sent, this retinal image, okay, from this myopic defocus will not be strong enough. So we need to create a big blur before the retina without compromising the quality of vision. So what we are going to do is what we call a caustic shape. The rays are going to have a blended distribution of myopic defocus in front of the retina. It's not only a single dot. So that the message and the contrast between good vision and myopic defocus will be very strong very quickly. And the stop signal will be sent very quickly. And so we will have results very quickly, okay? When I'm talking about a caustic shape, if you have never heard about it, you can imagine a glass of water and a light going through the water. And so when you move everything, you can extend or minimize the shadows, the image. This is exactly what we are doing. So we want to have an extension of a point, okay? So how do we do that? Care elements are rings at the front surface of the lens. We are going to divide those rings into two meridians. A radial one, okay, just in the middle of the care elements, and then an axial one, so through the care elements. We are going to create a power with the radial one, because as you can see, this is where we have a full curve and a planar surface, okay? As we have this full curve, we are able to create a positive power, which is plus 9.2, okay? On the other end, the axial meridian, as you can see, you do not have a full curve. You have half of it and a plano, which means that we cannot have a power. So finally, what we are creating, I'm still too quick, is what we call actually an astigmatism. You have two different meridians, an extended image as an astigmatism with a value of plus 4.6 dioptry. Okay, this is how we do to create this myopic defocus in front of the retina. The second technology is actually even more than the first one. As you've seen, this hyperopic defocus is not something brand new. We have competitors doing this, and we all have our technology. What you also understood is that it is the hyperopic defocus which is stimulating the myopia. So if you put whatever type of refractive elements in the front surface, but you do not minimize the hyperopic defocus on the back surface due to the aberrations of the peripheral part of the lens, the efficiency is not going to be that strong. This is why this clear focus design is very important. It's on the back surface, okay? It's a point-by-point, free-form, optimized back surface design. Okay? Thanks to this, we are going to minimize the aberrations. And so we are going to optimize the efficiency of the myopic defocus. So the second technology is really, really important in making the difference compared to all our competitors. This is actually a graph where we compare two types of lenses, -2, -4, one classic spherical single vision and myopia. From the center of the lens, where is the optical center, through the peripheral part, the colored part are showing the aberrations. Aberrations are measured thanks to spherical error. Okay. As you can see, a myopia compared to a normal single vision is already really minimizing the aberrations, even on a -4. We can even more see it on the graph in the middle. You see, you have same at the center in red, the value, the spherical error, so the value of the aberration on the peripheral part, and in blue on myopia. Blue is almost totally flat. You can even see the myopic defocus on the edge, and same for -4 lens. So yes, we are going to minimize the aberrations. We are going to minimize the hyperopic defocus. And yes, we are going to maximize the efficiency of the myopic defocus. So actually what we are going to do here is to take care of the moving eye behind the lenses, which would be actually quite the same as the contact lenses. Okay. Studies. This is one of my favorite parts because we are a lot into studies. At first, we were doing a lot of studies in China. Our partner from ever is Wenzhou Medical University, Eye Hospital, and actually Dr. Wang is going right after me, going to share some tips about myocare. But right now, more than 1,000 children are under studies, okay, in Asia, but also in Europe. The studies that I want to talk to you about is a 2-year study, but we just received the intermediate results, so after 1 year. We did not expect those results, and actually we decided to change what we wanted to do about myocare. Let me explain. This study is about is blinded randomization, of course, about 240 children having myopia. Okay, we decided to divide those children into 3 groups. A first one trying what we are going to call Zeiss myocare soft design. A second group trying Zeiss myocare hard design, and a single vision control group. I'm going to talk about those 2 designs in the next slide. We are asking them to come back every 3 months. We measure the spherical, the refraction, axial length, and quality of life, okay? As I said, we had been trying 12 different designs, and actually, this study was supposed to help us to find which design to keep. So you have a hard design, which is the design I just described before, and you have a soft design. The difference actually is quite simple. It's exactly the same concept, but the value are going to be different. On the hard design, the central zone is 7 millimeter, when it's 9 millimeter on the soft design. The mean additional surface power is plus 4.6 on the hard design and plus 3.8 on the soft design. But the distribution at the surface between myopic defocus and regular vision is the same, 50-50. And so it's great to have studies. It's really, really great to have studies, and it's even better when you know exactly what to compare. It's really interesting to come at the end of this webinar because most of you actually understood that it's really difficult to measure the efficiency of a lens. There are too many parameters actually. If your parents are having myopia, if you have an Asian DNA, if you are spending 8 hours outside playing football, or if you are just inside spending 12 hours on a screen, it's totally going to be different. You can do a study before COVID and after COVID with exactly everything same, and you will not have the same result because we cannot control everything. So, and having to look at a single group and a comparison to 2 other groups in a study doesn't really have a meaning about myopia management. because there are too many parameters. So we were looking for a way to try to measure the efficiency of an optical lens for myopia management. And what we wanted to know is there a normal curve of a growth of an eyeball of a children who is emmetropic? Can we do a curve, a normal curve of a growth of an emmetropic children, as we do when you give birth to a baby? You know that the weight and the age and the height should follow a curve. Can we do the same for the growth of an eye? And actually, yes, we can. So we took all data we got for children, okay, emmetropic children from USA, from Asia, from Germany, and we put all them together in this graph. And so we saw that, yes, there is a curve of a normal growth for children between 7 to 16 years old. So actually, what we want is to bring back the evolution, the progression of the axial lens as close as possible as this curve. We want you to have normal data which are going to help you to understand and to monitor the myopia management that you're doing in your practice. So let's come back to our study. What is happening when we put the data of the three different groups compared to this normal growth? The black line of this graph is the normal growth of an emmetropic eye. The red one, the red line, is the myopic growth of the single vision, okay? Then you have the dark blue line, which is the Zeiss MyoCare hard design, and the blue dotted line, which is the Zeiss MyoCare soft design. And so what do we see? We see something very interesting, which is that the Zeiss MyoCare hard design is more efficient on children from 7 to 9 years old. As you can see, the curve is closer to the normal. But from 10 years old, it is the Zeiss MyoCare soft design which is having the best efficiency. So finally, we decided to keep both designs. We are going to have a portfolio of age-related MyoCare lens. Let's have a closer look about results and value. What is also interesting here is that it's only 12 months studies. When I said at the beginning of the presentation that we wanted to have results and quickly, right? Here we don't need to wait 2 years. We don't need to wait 3 years to see the results. We already have results after 12 months. So for the 7 to 9 years old children wearing the MyoCare hard design, we can have an average absolute reduction of progression of axial length of 0.14 millimeter, and an average absolute reduction of progression of spherical equivalent refractive error of minus 0.22 dioptry. This is a lot. This is really a lot, because this is what in myopia management a child can have as a yearly progression. So the first year, we already stopped this. This is really, really good result. What about the MyoCare soft design? Average, an absolute reduction of progression of axial length of 0.13 millimeter, okay? So for children from 10 to 12 years old. And the refractive error is even bigger, minus 3.33 dioptry. So this is very, very efficient with only a 12 months study. But it's really efficient when you adapt the type of lens to the age of the children. What we can say and what we saw from the presentation before that one is that younger children are having a more aggressive myopia evolution. So to put to them what we call the hard design is logical. This is what is going to really stop this elongation quickly. The other thing is that when you are 10 years old, 12 years old, 13 years old, it's not going to be your first glasses. You are already used to something different. So maybe the soft design is going to be easier for them, okay? What is sure is that results are here. I always said, and I'm going to say that wearability is mandatory. If it's not comfortable, it's never going to work. And great news, it is very comfortable. From the same studies, 240 children, 100% of them adapted to Myocare, both design, within 1 day. We have very good comfort in distance vision, near vision, and even being active practicing sport, okay? This is really good result, once again, on both design with age-related lenses. Now let's talk about how do we do that? This is quite simple. So to prescribe, first of all, it's just age-related. All children below 9 years old, we really suggest to prescribe Myocare hard design, Myocare normal. From 10 years old, Myocare soft design. As Murtuza said just before, the choice of the frame is really important. There is nothing really more difficult than any regular spectacles for children. It has to fit very well on the nose. It has to be big enough, not too low, otherwise the children is going to be like that. It has to be not too high, otherwise the cheeks maybe are going to touch, very well adjusted behind the ears. Nothing much too complicated, right? But yes, you have to take your time. And for having been in stores here, sometimes you need to educate parents and to explain to them that this fitting is not good. It's too big, it's too wide, it's too small, whatever. It's a no. Because here we are talking about a treatment. This is not just glasses. This is a treatment. This is totally different. So no, those glasses are too small. Twice I have to listen to you. I know it's hard, but you have to. That's your condition of eye care professional. You have to advise, and sometimes you have to say no. What about centration? Quite easy, PD, right and left eye. And then you have to take the height. This is an aspheric lens, which means that you need to take care of the value of the pantoscopic angle. It's really easy. An aspheric height, you measure it by taking the full pupil height, the regular one, then you remove 0.5 multiplied by the value of the pantoscopic angle. So for example, you have a full pupil height of 18 millimeters, a pantoscopic angle of 8 degrees. Then you take 18 minus 4, and so the height will be 14 millimeters. That's it. So nothing very, very complicated. This Myocare hard design and soft design are now available in 1.59 with Dry Vision Platinum. We are working on different indexes. We are working on another anti-reflecting coating. It's going to come soon, hopefully, but for now, you can have 1.59. Those lenses are already available in UAE, in Qatar. It's going to come soon in Saudi. It's also available in Nigeria, Israel, and Lebanon, okay? Something on top of that, which is really important, and I'm sure you will approve that, is that we have a full Zeiss Myocare warranty. 1 free power change up to 9 months. Once again, it's a treatment. So if in 9 months you need to change whatever value it is, the lens, we do it for free, okay? In adaptation, if there is any inadaptation, we change the lens with a Smart Lifelong, a single vision lens. Scratches, cracks, as you've seen, the small size of the lens. If there is a big scratch on it, it's never going to work. So we do a 70% discount on first replacement, 50% discount on second replacement up to 1 year. And you have any coating damage as usual due to manufacturing defects, of course. We have a full range of marketing tools that can be useful to you. We have display that you can show directly to parents or to patients. You have a customer leaflet, and what we have, which is really, really important, is a follow-up booklet. Every time that we are going to dispense Myocare, parents will receive this follow-up booklet. Inside, you can write all follow-up appointments. You can write all info about measurements, refractive error, type of lenses, and everything. This is the best tool to improve communication between all eye care professionals. Okay. Then we have some post-it. This is more for ophthalmologists in hospital, where they can prescribe easily and find all the eye dealers. One last thing very quickly. At the same time as we're launching Myocare, we are also having great lenses for the other children who are not having myopia progression. So it's named Smart Life Young. We have two types of lenses, one for the 6-12 years old and one for the 13-19 years old. So what are those lenses about? We made studies to optimize the vision field for a children. So what we saw is that the distance, the near object distance over age is really, really different. When it's 20 centimeters for a 6-year-old child, it's 30 centimeters for a 19-year-old child. So very different. Pupil dynamic is also growing up and having a big impact on quality of vision. And then, as you know, we are doing a lot of customization, and all those parameters like PD, of course. Yes?
Sorry, you just have 1 more minute to wind up, please.
Yes, I finish.
Yes, yeah.
Thank you for interrupting.
Sorry.
So, yeah, we have 60% wider fields for all type of children from 6 to 19 years old who are not having myopia progression. Finally, this is the last slide. I just would like to talk about something which is really important. Who can prescribe Zeiss Myocare? It's really depending on the state, on your country regulation. In Nigeria, we can do cyclo refraction. Here, optometrists cannot do it. It's really, really different from a country to another one. What we suggest is that if you cannot do a cyclo refraction and the patient is in need of a cyclo, please refer to an ophthalmologist. If from 15 years old, you think that a cyclo is not needed, then you can do the refraction, you can prescribe Myocare, and you can do the follow-up. If you have a children coming to a store with a prescription and you think that Myocare would be a good match, a good solution to slow down myopia, please call the ophthalmologist or send him an email, whatever, but please explain to the ophthalmologist that you think that there is another option for his patient. Wait to have their approval before selling any Myocare. This is really for you. There is we all eye care professionals have to work hands in hands about myopia management, and communication between all of you is really, really important. This is why the follow-up booklet can be a very good tool as well. We can send you an already made email with an explanation about Myocare if you want to send it to ophthalmologists. And so here I am, I'm done. Thank you very much.
Thank you, Celine. That was awesome. And thank you so much for taking us through Myocare lenses. Okay, now it's time for recap and Myo quiz. Good luck to all. So QR code will be scanned now.
We welcome you everyone to this Myo quiz. To learn Are you excited? Let's countdown start. And here it is. You will get 30 questions and need to answer in the specific time limit. Please scan the QR code right now from the screen to get access Myo quiz live page. QR code and access link you can find in the Zoom group chat as well. It's already shared there. QR code and access link you can find in the Zoom group. Countdown will start as soon as you log in the live quiz page. Fill up the form and initial information and start answering. Submit the form once completed. There will be no access once countdown stops. Hence, form will be submitted automatically. 3 winners will be announced and will be awarded with exciting gifts. But winners must be registered participants of this run. First 200 submission will be accepted for the evaluation. After 10 PM Dubai time, no form will be accepted. Regarding the winners, decision will be the final for the committee. Thank you everyone for participation. Over to you, Canning.
Fine. Now I would like to invite Ms. Yuan Wang for the final talk of the event. She is here to share a clinical case in patients with visual dysfunction for myopia control. And she is currently the director of the optician department at the Eye Hospital of Wenzhou Medical University. Over to you, Ms. Yuan.
Hello, everyone. It is an honor to be invited to this International Forum for Myopia Control and Management. I'm Dr. Wang from the Wenzhou Medical University, affiliated eye hospital in Zhejiang province in China. I'm delighted to have this opportunity to communicate and share the clinical case with all of you online. Today, I will present clinical cases about the fitting of myopia control lenses, named care lenses. At first, let me introduce myself. I'm from a top 3 ranked ophthalmology specialty hospital in China. I have been working in the business and amblyopia department for over 20 years and specialize in pediatric optometry and clinical management of business and amblyopia. My department has approximately 300,000 outpatient visits per year. Personally, in the past year, I have checked 6,600 patients in my outpatient clinic and prescribed over 600 pairs of myopia control lenses. I'm very honored to share you the clinical cases of fitting myopia control lenses and the follow-up process. At first, let me introduce the clinical procedure for fitting the size care lenses. The first step, we performed clinical assessment, including medical history. During the history-taking process, we inquired about the parent's myopia status to confirm if there are any genetic factors related to myopia. We then proceed to evaluating the patient's visual acuity, conducting both subjective and objective refraction tests. To monitor the progression of myopia, it will be important to measure the parameters such as axial length and other biometric parameters of the eye. A comprehensive eye examination is carried out to rule out any organic eye diseases. It is important to emphasize that we need to evaluate the patient's visual function, including Fourier examination, accommodative amplitude and accommodative facility, and converging near point, as visual function can influence the onset and the development of myopia. For patients with poor visual function, it is necessary to improve their visual function before proceeding with the fitting of myopia control lenses. Next, we proceed with the clinical fitting process, which involves selecting an appropriate frame. We prefer frames with nose pads for children as they allow for easier adjustment. After choosing the suitable frame, we should accurately measure the monocular pupillary distance and height. We recommend that children wear the glasses at least 12 hours per day to maximize the effectiveness of myopia control. Additionally, we provide the education to both the child and the parent, giving them the proportions and instructions for how to use the lenses effectively. Consequently, we recommend follow-up visits every 3 months. During this visit, we re-evaluate visual acuity, refraction, and axial length to monitor the progression of myopia. We also assess the status of visual function and make any necessary adjustment to the frame. Furthermore, we inquire about the child's compliance and wearing habits. Some patients need to be carefully fitted with myopia control lenses. For example, patients with strabismus and amblyopia are not recommended to wear myopia control lenses. For those with abnormal binocular visual function, it is recommended to do vision therapy first to improve the visual function before selecting the appropriate lenses. Caution is also needed in patients with intermittent exotropia. Next, I will share 2 clinical cases. Both of them are about clinical matching of myopia control lenses for patients with visual dysfunction. Let's begin with the first case. This is an 8-year-old girl who had been experiencing blurred vision when looking at the blackboard with original glasses for over 1 month. She wears glasses only during class for distance in daily life, and the previous prescription has been used for only 6 months. Her parents were nervous and asked for myopia control. We compared the old and the new prescriptions of the girl, found myopia had increased significantly, more than 1 diopter during the past 6 months. Her visual function assessment revealed that she had a latent axial deviation of 10 prism diopters at near distance, and her near point of convergence was more far at 10 and 15 centimeters. We considered she had convergence insufficient. In addition, the accommodation parameters showed that the patient's accommodative amplitude using the minus length method were 6 diopters of the right eye and 8 diopters of the left eye, which were significantly lower than the normal value for her age. The flexibility of accommodation presented that the girl was unable to achieve clear vision with minus lenses, indicating accommodative insufficiency. Moreover, the patient's axial length has increased by more than 0.4 millimeters over the past 6 months, suggesting that the increase of myopia diopter was matched by the growth of the axial length of the eyes. For this patient, no other abnormalities were detected during the examination of the eyes. Let's think about the characteristics of this patient. First, she had a rapid progression of myopia, and the parents had a strong demand for the prevention and control of myopia. Second, the girl wears glasses irregularly in daily life, which may contribute to the rapid progression of myopia and poor accommodative function. So, based on the results of the visual function examination, the patient presented insufficient accommodation and convergence. We could confirm the diagnosis of pseudo-convergence insufficiency. Pseudo-convergence insufficiency is a condition in which the primary problem is accommodative insufficiency. The amplitude of accommodation and all other tests assessing the ability to stimulate accommodation are reduced. It is believed that this condition is basically an accommodative insufficiency with a secondary convergence insufficiency. After understanding the characteristics of the patient, we can provide the appropriate solution. Firstly, vision therapy is necessary for the patient to improve the ability of accommodation and convergence. Secondly, we asked the patient to consistently wear glasses, especially during near-work activity. Furthermore, we recommend the use of myopia control lenses, care lenses, to slow down the progression of myopia. After vision therapy in hospital for 2 weeks, visual function of the girl had been greatly improved. Then she began to wearing myopia control lenses all day. During the wearing process, the patient was advised to perform 15 minutes of daily home visual training, using flippers to do accommodative training and 3 dots card for convergence training. The follow-up was be arranged after 3 months. After 4 months of wearing glasses, the patient came again. She was no complaints about discomfort, and with only slight visual instability at the initial stage of wearing, which gradually relieved. Let's review the results of eye examination. The visual acuity with glasses was good in both eyes. Foveal status was never changed. However, there was a significant improvement in the near point of convergence. It was 3 and 6 centimeters in the normal range. The accommodative function examination showed that after vision therapy, the patient's accommodative amplitude in both eyes approached normal levels, and there was a significant improvement in accommodative flexibility. The exciting thing is, after 4 months wearing, not only was the patient's visual function significantly improved, but the axial length of the eye was controlled. This case demonstrates that patients with abnormal visual function can successfully be fitted with myopia control lenses after vision therapy to improve their visual function. Let's now follow on the second case. This was a 9-year-old boy who underwent intermittent exotropia surgery 3 years ago. She had experienced rapid myopia progression, and for the past 3 months, he was unable to see clearly at distance while wearing his current glasses. He was consistently wearing glasses, and the previous prescription was prescribed 7 months ago. The parents requested a re-evaluation of his prescription and asked for myopia control. The original prescription indicated moderate myopia with astigmatism. Subjective refraction revealed an increase of 1.5 diopters in myopia for both eyes. Cover test with prism showed intermittent exotropia of 10 prism diopters at distance and 16 prism diopters at near, indicating he had residual exotropia after intermittent exotropia surgery. However, his fusional control ability was good, and the near point of convergence was normal. Fusional vergence reserves indicate inadequate convergence ranges at both distance and near, which did not comply with the shared law. Accommodative function examination showed normal accommodative amplitude, but the accommodative flexibility test revealed an inability to relax accommodation with plus lenses, indicating the patient was in the status of accommodative excess. Exolens measurements showed an increase of over 0.5 millimeters in the past 7 months, which closely corresponded to the increase of myopia. Eye examination revealed allergical conjunctivitis, but no other abnormality was found. Let's summarize the clinical characteristics of the patient. According to the medical history and the clinical examination results, the patient can be diagnosed with residual exotropia following exotropia surgery. Given that intermittent exotropia and myopia often coexist, meaning that patients with intermittent exotropia are prone to rapid myopia progression. So this patient requires myopia control urgently. Due to the presence of allergic conjunctivitis, the patient is not suitable for ortho-K lenses or defocus soft lenses for myopia control. Considering the characteristics of the case, although the patient has residual exotropia, it can be controlled well in the primary position, and the amount of deviation is small. So we considered it can be treated well after vision therapy to improve the fusional vergence and accommodative facility. Our proposed solution is as follows. To carry out vision therapy at first, to expand the patient's fusional reserves and improve their accommodative status. Then ask the boy to wear the myopia control lenses after visual function promotion. Therefore, we ordered the myopia control lenses for the boy, but we asked him to do vision therapy in hospital at first with the regular frame glasses, accompanied with home therapy of 15 minutes per day, including fusional vergence training and accommodative flexibility training. After 1 month of vision therapy, we would conduct a follow-up examination to assess the patient's visual function. Let's take a look at the results of the visual function re-evaluation after 1 month of this therapy. Although the amount of strabismus has not changed, there has been a significant improvement in the range of fusional verging. Accommodative flexibility has also shown noticeable improvement. Due to the significant progression observed in the patient's visual training, we asked the boy to wear myopia control lenses all day. As the patient still has a slight degree of exotropia, we have advised him to continue with the hospital vision therapy and the daily home therapy. A follow-up examination of visual function will be conducted after 1 month. During the follow-up examination after 1 month of wearing myopia control lenses and vision therapy both in hospital and at home, the patient reported no discomfort with the new lens. The amount of strabismus remained the same as before, but there was further improvement in the range of fusional verging at both far and near distance. Accommodative flexibility was in normal range, and fortunately, there was almost no changes in the eye axial length. The result was so encouraging, and we instructed the patient to continue wearing care lenses and only carry out home therapy, and asked the patient to follow up after 3 months. Let's review the follow-up examination after 3 months. The patient's visual acuity still remained stable throughout the process of treatment. The amount of near strabismus decreased by 2 prism diopters compared to what he was before, indicating improved fusional control ability and further expansion of the fusional verging range, and conformed to the shared rule. Accommodative function remained within the normal range, and there was still no growth of the axial length. Through this case, provided the evidence for us and give us the confidence that intermittent exotropia patients with good fusional control ability can consider to using myopia control lenses effectively. However, it is important to monitor the visual function status during the follow-up process. Based on the above 2 cases, I believe that everyone now has greater confidence in myopia control lenses fitting for children with visual function abnormalities. By improving the patient's visual function through vision therapy and incorporating with myopia control lenses, we can effectively delay the progression of myopia. These 2 approaches can be perfectly combined to achieve optimal efficiency while maintaining good visual function. Thank you very much for your attention.
That was a wonderful case discussion by Ms. Ewan. Unfortunately, she is not available for the panel discussion. Okay, great talks. And now we have come to the end of the session. We have come to the end of the event too.
What do you think, Kenny? The 3 AAA which you discussed earlier, is it fulfilled?
Of course, yes, SK. The speakers today did a good justice to the topic by bringing in well-researched, pertinent, and developments in the field, thus fulfilling all the 3 A's. What do you think?
That's true. Awareness, which we are able to create throughout attendees all over the globe. Acceptance, which our eminent speakers took us through evidence-based accepted pathway for myopia control and management. And the third one, accomplishment, which starts with decision to begin. We could achieve this together as a team, which includes ophthalmologists, optometrists, orthoptists, ophthalmic technician, and ophthalmic nurses from all over the globe. And we promise we'll continue this journey for sharing knowledge throughout the year. As our next big event, on-site conference, October 4th, scheduled on 14th October 2023 in Dubai. We would like to see you all there.
Also, our quarterly newsletter, OptoKayak Edition 2, will be released soon, where we will announce a Myopia winner and the highest attendee award winner for the webinar. And now I would like to call upon Ms. Sana to deliver vote of thanks. Over to you, Ms. Sana.
Good evening, everyone. As we come to the end of this session, I would like to thank everyone for participating and being present until so late. Let me take this opportunity to express my gratitude towards our speakers today who shared their experience and knowledge with us. A special thanks to Emirates Society of Ophthalmology for endorsing this event. Dr. Omnia has been supportive always, and we would like to express our gratitude towards her. Our sponsor partner, Zeiss Vision Care, special mention to Mr. Badawin, who has given us this opportunity to spread knowledge with our eye care practitioners. We look forward to working alongside with you for many such events. Thanks to Ms. Celine to approach us for this event. Lastly, would also like to mention UAE Indian Optometrist Forum organizing committee who has worked behind the scenes to make this event successful. To all the participants, your certificates will be available within 15 working days on the registered email address. Visit our website www.optoverse.site for any further updates. Looking forward to see everyone at our on-site event, Optoverse 4 on October 14th, 2023. Signing off from here for now until we meet again. See you. Good night, everyone. Bye-bye.
Thank you.